afternoon, distinguished guests, dear colleagues, and ladies and gentlemen. It is a true pleasure to welcome all of you to the interactive seminar on this important issue on depression. Let's talk about what we all should know, organized to mark this year's World Health Day. It is an honor to have distinguished delegates from Department of Psychiatry, University of Melbourne, Institute of Human Behavior and Allied Sciences, participants from prestigious institutes from different parts of the world and India. Thank you. Almost only 3 years since its conception, Jindal Institute of Behavioral Sciences has grown exponentially on all fronts, be it research, community engagement in the form of teachers training programs, management development programs, outreach in the form of counseling, peer education, or toll-free helpline number. JIBS is reaching the heights of research, community, and academic excellence. With research projects in the area of mental health, cybercrime, victimology, gender-based studies, neuropsychology, leadership and change, Jindal Institute of Behavioral Sciences has over 10 funded research projects with international collaborations. As a part of community engagement initiative, JIBS have provided training to over 1,300 schools with over 7,000 school teachers, principals, and students as participants in different parts of the world. All of this have been possible because of vision and leadership of one man, our Vice Chancellor, Dr. C. Rajkumar. Before I invite him to the podium, I would like to place it on record that it is his unstinting support and encouragement towards making OP Jindal Global University to the heights of academic and research excellence with a social commitment provides us with the vision to strive for academia to reach out to the society. So, can I have you all over the stage?
Good afternoon to you. Thank you very much, Garima. First of all, I want to extend a warm welcome to our partners in this endeavor. I would like to begin with thanking and appreciating the leadership of the Jindal Institute of Behavioral Sciences, its Principal Director, Dr. Sanjeev P. Sani, for his vision that has indeed transformed the Jindal Institute of Behavioral Sciences from a very modest beginning that it had a few years ago to a fledgling research institute which is contributing to various aspects of research, teaching, training, capacity building as well. I also want to particularly recognize the distinguished presence of our partners from the University of Melbourne, the Department of Psychiatry at the University of Melbourne, the Asia, Australia, Mental Health, as well as Indian organizations which are also part of this effort, our partners here from India. I also want to recognize the fact that several months ago, I had the privilege of visiting Australia and the University of Melbourne, and we had a meeting with the colleagues here from the Department of Psychiatry, and that meeting and conversations thereafter, and also the leadership of JIBS has culminated in today's seminar. And it's, of course, the seminar is organized a day before the World Health Day 2017, the theme of which has a very strong focus on depression itself. You know, there is something to be said about the idea of collaboration, and great ideas have come through the possibility of institutions doing things together. This is an example of India-Australia collaborative effort. This is an example of academics coming together to discuss about issues that are of global significance. It is also an example of how, if and when academics and institutions come together, we can make a significant impact on various aspects of research. This morning, the faculty members from the Department of Psychiatry at the University of Melbourne visited our campus. They had some extensive discussions with Dr. Sanjeev Sani as well as his colleagues at the Jindal Institute of Behavioral Sciences, followed by some meetings with me and my colleagues. And in a way, this seminar, I believe, has the potential to build partnerships that are going to not only bring Australia and India together, but also both our universities together. I mentioned, and of course, while other speakers will speak a little bit about the theme of today's seminar, my job is to really, briefly introduce the university, but I am conscious of the time, so I'll keep it short. the Jindal Global University was created as a philanthropic initiative of our founding chancellor, Mr. Jindal. The vision was to create an institution of global excellence in India in a multidisciplinary framework, and that has culminated in we traveling an extraordinary journey since the year 2009 with barely one school, the Jindal Global Law School, and 10 full-time faculty members and 100 students. Today we have grown significantly with 6 different schools in law, business, international affairs, public policy, liberal arts and humanities, as well as journalism and communication. We have over 230 full-time faculty members and nearly 3,000 students. Besides these 6 schools, we have a few important research and capacity building institutes, the pioneering of which is the Jindal Institute of Behavioral Sciences. I mention all of this because of the fact that we are only 7 years old. JIBS itself is only 3 years old. And this journey that we have covered has been because of the wonderful academic leaders as well as administrative staff, research associates who have been part of this effort. While Dr. Sani had provided leadership in JIBS to conceive the idea and take it forward, it is the dynamic leadership of his staff members such as Garima Jain, who many of you have interacted with, Manjushri and Polumi and others, who have really taken the mantle of leadership in collaboration with the students who are volunteering and part of the research environment. I want to mention to the University of Melbourne faculty and staff who are here that this extraordinary opportunity that we have to collaborate together in discussing some of the big issues of our time is an opportunity for us to look at issues surrounding depression, not only from the standpoint of the shared experiences and learnings that we bring forward from both the countries, but also the shared experiences and learnings that we come from within several disciplines. The history and evolution of a problem like depression involves a number of disciplines, including not only the diagnosis of it, but also response to it, both at the level of health intervention, but also at the level of policy engagement, including disciplines such as psychology, sociology, anthropology, law, as well as medicine. And there are many more disciplines that have a profound impact and also informs our understanding and knowledge about depression. This is an example of what universities can do when they come together. We are very proud of the fact that we want to engage with Australia and with the University of Melbourne in a very significant manner. We strongly believe that India has not yet acquired a stronger imagination for Australia, although we, some of us in the academic communities know the prestige and reputation of the leading universities in Australia, such as the University of Melbourne. Most of India and most of Indian academic institutions, including faculty, students, have very little knowledge and understanding of Australia, let alone Australian higher education institutions. This collaboration, I hope, can bring forward new ideas, new perspectives, as well as a more substantive engagement towards advancing research relating to various aspects of mental health, including the problem of depression. So I would like to stop here by once again welcoming our partners and colleagues from various institutions, in particular the University of Melbourne. I also want to recognize the distinguished presence of one of our other partners here, Professor Dr. Sharon Canahan, who is a professor at the Rollins College in Florida, which, as you know, is a very close partner of our university, particularly the School of Liberal Arts and Humanities. Thank you, Sharon, for your presence. I also want to recognize the presence of very distinguished individuals who have taken the time out, in particular, Professor Dr. Nimesh Desan, who is the director of the Institute of Human Behavior and Allied Sciences. He has been a strong supporter of our initiative and our university. I remember very well a couple of years ago in the same venue when we organized one of the earliest consultations relating to the mental health bill. Professor Desai played a leadership role and since then has been also visiting our campus and working closely with JIBS. So in some ways, this is an opportunity for all of us to come together, both from Australia and from India, from different academic institutions, professional organizations, think tanks, research institutions, to engage on a critical issue that is facing both India and the humanity. Thank you.
Thank you, Professor Rajkumar. I would like to call on the podium the one man without whom this evening would not have been possible, the person behind the conception of Jindal Institute of Behavioral Sciences, our Principal Director, Dr. Sanjeev P. Sahani. May I please request you to come on the dais?
Thank you, Garima. In fact, all of these formal words, which Rajkumar or Garima is talking about me, I was not even in country when they decided to have this seminar. I just got the information on such and such date. We have booked the hall, and you make sure you are there at 3 o'clock. And I didn't do anything, to be very honest, but it was a great pleasure meeting the counterpart from the Department of Psychiatry, Melbourne University, spending good 3 hours with them, learning many things. Thank you, Professor Desai, for allowing us to use your logo and, providing us the resource person. Being a psychologist, I want to talk about few things. I'm a failure as a psychologist in India. I would like to be, I mentioned this you very clearly. Why? Most of the psychological courses we are offering as a bachelor's and master's in India, and to a certain extent the PhDs, there are hardly any known institutes. I can name 3 institutes, Bangalore and Delhi or maybe Ranchi, and I don't know the 4th institute, now maybe JIBS. So, so the point is, and I've been from the UGC side, I go to all these universities for accreditation for psychology courses. There are no laboratories. There is no assessment system. We are basically trying to educate our students. There are major issues in the field of mental health. I remember that first National Symposium on Mental Health. We did it with Dr. Desai. This was on 12th March 2013. And we remember that. First of all, to the audience, I want to let you know that there was a Lunacy Act in 1912. It took us 75 years to change from Lunacy Act to the Mental Health Act. 75 years. And there was a lot of lacunas in that. In 2010, when the government decided to have a new Mental Health Act, it took them again 7 years to come out, and I'm so happy that it is out just probably last week or 10 days back. Again, there are quite a lot of lacunas, and I know why, because the people sitting here, those who are actual workers, they have not been consulted onto these kind of things. I want to give you a little statistics about mental health. India and China, together, they have 50% of the total depressive population in these 2 countries. Because we have more population, that may be the reason. But it's a 4% in men and 5% in women, which is same as in UK. In Australia, it is 5% in men and 9% in women, which is same in USA. But the figures which I'm giving it to you from India is never ever reported even. I want to talk to you about the society and the family issues relating to mental health problem. First of all, are our parents can understand the behavioral issues and the mental health issues of their children? And if someone asks them, if I ask Professor Rajkumar that please visit a psychologist for your son or a daughter, he's never going to like this statement. Because the stigma attached with the word psychology, psychiatrist is extreme, in fact. So, that people are not interested. They're not. And whereas when I was studying in US, and it was a status symbol that who is your psychologist for your children, and then you say so and so, say, oh, wow. So, there is a basic problem we are facing. How many of our parents can virtually recognize that their children are having a problem? Learning disability is a major issue. And I know that 16% children population is suffering from learning disability. Tell me there is any test, diagnostic test, which we have developed in India, standardized on India, which we can use it? I don't think so. I know IBAS may claim certain things, but I want to know that whether it has reached to all the schools to administer those kind of tests or not. It's not there. The third and the most important thing is the society. How many of us are ready to employ mentally challenged people or having some sort of mental challenged, any kind of uh, mental problems a person is suffering from? How many of us is ready? Forget about that. I want to talk about the government now. If I talk about the total, if the total budget of the India, only 2.27%, I'm giving you the figures of 2017, 2.27% goes to the health, which is very small. And out of that, only 0.0036 goes to the mental health. When my government doesn't want a healthy people around, or they're not caring about them, what can I do that? Tell me the institutes where, we can easily, we can feel confident sending our children, students for assessment, treatment, rehabilitation. It's a major issues. And that's why I'm very thankful to Professor Rajkumar and to the University of Melbourne to come all the way for this seminar. I'm very grateful to Sharon from Rollins. We are all collaborating. And I'm not going to take much time, but Jindal Institute of Behavior is open for all of you, and we are ready to learn more and more. The best thing what we are doing at the moment is, as Garima just mentioned, we have covered over 1,200 schools. We go to each and every school. We train their teachers. We have trained almost 7,000 or 8,000 teachers and principals on mental health issues. And we are very happy that we are contributing to the society through Jindal Institute of Behavioral Sciences and OP Jindal Global University. Thank you very much.
Thank you, Dr. Sani. It is my proud privilege to introduce Professor Ian Everall, the Cato Chair of Psychiatry and Head of the Department of Psychiatry at the University of Melbourne. Not only he is the Director of Research Northwestern Mental Health and an Honorary Professorial Fellow at the Fleury Institute of Neuroscience and Mental Health, but he is also a published author with over 170 publications and over $50 million in research funding to his name. Professor Everall has been at the forefront of research into cellular, molecular, and genetic changes in the brain in major psychiatric disorders for over 20 years. The topic of his discussion today is an evidence-based research on depression, its prevalence, causes, symptoms, and most effective treatment. Sir, may I please request you to come on the podium?
Thank you very much. While we get the presentation going, I just want to acknowledge the Visionary Vice-Chancellor of Jindal Global University, Professor Raj Kumar, as well as the Director of the, of the Jindal Institute of Behavioural Science. We had a great morning with you and your staff today, and very impressed with the amazing amount of work you're doing. Thank you. Are we all ready? Great. So I'm going to talk to you about depression. I'm going to tell you a few salient facts. We're not going to go into much molecular work because that will just put you all to sleep. So depression, unlike many other psychiatric disorders, has been written about, has been suffered for thousands of years. We can actually go back to some writings even from ancient Mesopotamia and the second millennium of the Greek society to find descriptions of people suffering from depression. I've even put an image there of Hippocrates, who's considered the father of medicine. He also described depression. And he believed that depression, like other diseases, occurred naturally and were not due to superstition or the intervention of gods. So that was pretty a good step forward. And the old-fashioned name for depression was melancholia, describing a sadness. We now know today, and this is the only time I'm going to get to a bit of science, that there are changes in the brain of people who are depressed. My and other groups around the world have shown that there are cellular changes. We know that the chemicals, the neurotransmitters that communicate between the different neurons are also affected in depression, and our main medications for depression are to restore the normal balance of those neurotransmitters. And here we can see Professor Kumar gave me a very nice present today, which has got a laser pointer, so I'm going to use it for the first time. So this is a figure of a diagram of a synapse showing the connection between one neuron and another, and the connection is chemical. So chemicals are released into this synapse, and then there is communication to the other neuron. These chemicals are altered in depression. It is an absolute disorder, it's an illness, a disease, whatever you want to say. It's not due to weakness, and we should really work hard to destigmatise it. How common is depression? It's estimated from epidemiological studies that over 300 million people are suffering depression around the world. That's about 4 to 5% of the world's population. It's huge. It's ranked by the World Health Organization as the single largest contributor to global disability. And I'll talk about that disability a bit later. It's believed that almost 8% of all years lived with disability in 2015 were due to depression. So again, major economic effects, which I'll talk about a little bit later in the talk. And as we all know, people who suffer from depression have much higher rates of suicide. And that's a tragedy, and that's something we should try and prevent. And I'll talk about suicide later on. And we think that people with depression amount to almost 1 million suicides every year around the globe. This is something we could do a lot about, intervene early, recognise and treat those people, and take those list of suicides down. I'm obviously biased, but I think depression is a global health priority. And we know that the number of people suffering from depression is rising because of the changes in the world. And this is especially occurring in lower or middle income countries where the populations are still growing. We know that globalization is having an impact on traditional family structures. People are leaving their families, they're moving to cities, they've not got the supports they normally have, so they're more vulnerable to develop disorders such as depression and anxiety. And we know that the coping mechanisms are becoming more fragile for individuals in rapidly changing communities, especially those that are rapidly urbanizing across Asia. And it is stated that for women throughout the world, depression is the leading cause of disability. That's quite a statement. I'm now going to show you how depression and psychiatric illnesses contribute to disability throughout the world. So here is a pie chart of non-communicable diseases showing which type of disorders contribute to disability every year, whether it is disorders of the digestive tract, the respiratory system, cancer, and here are the psychiatric or the neuropsychiatric disorders, amounting to a massive 28% of all disability. These are huge problems, and out of that 28%, 10% is depression, much higher than schizophrenia. And it is estimated that by 2030, depression will be the largest contributor to the global burden of disease. So this is something we need to do something about. We need to destigmatize it, we need to recognize it, we need to treat it. Here's a graph that's not come across very well, showing the prevalence of depressive disorders in different geographical regions. The dark blue are females, the kind of light green are males. You'll notice that although there are variations geographically, it's about the same of about 5 to 6%. And also note that the rates of depression are higher in women. Doesn't matter which geographical region you are in, they are higher in women. Remember that. Because when we then look at suicides, dark blue are male, light green are female, the suicide rates are universally much higher in men. So women suffer more from depression, but it's the men who commit suicide. And you know, the suicide rate varies from country to country, and you can see for men in lower or middle income countries in Europe, it's almost 25 suicides per 100,000 population, as compared to other areas where Eastern Mediterranean, where it's down to about 5 suicides per 100,000. So depression is more common in women, but suicide is more common in men. And here are some figures from India from the years 2000 to 2012. This is the women, and this is the men. You can see there's a peak in suicide rates at the ages of 15 to 30 years in the women, and then it goes down. That rate remains high and stays high as the age goes up, even past 70. So again, there is a difference in the rate of suicides in men compared to women, and that stands up even in India.
Can I request you to speak closer to the mic?
Okay. If you can't hear me at the back, just wave. So I've outlined the size of the problem. What about the cost of the problem? Despite having very effective treatments for depression, fewer than 50% globally receive any treatment. That's bad. And across 36 largest countries of the world, it's projected that more than 50 million years of lost productivity occur because people are not being treated for their depression. And that's at a cost of almost $925 billion. So the economic effects of untreated depression are quite staggering. If we did treat people, though, the actual improvement in economic productivity would give us a net gain. It's been estimated 230 billion. And this was published last year in the Lancet Psychiatry. So it's a figure I rather believe. When we think of the cost, economic cost of depression, there's two types of cost. There's direct health cost, how much it costs to go and see your GP, how much it may cost to get treatment, etc. And then there are indirect costs. And these indirect costs include the fact that people don't perform so well at work, they may take time off work, they may even lose their job and become unemployed. Or even if they are at work, what a thing called presenteeism, they're not working as effectively as if their depression was treated. And also, untreated depression can have an effect on marital and family relationships. People don't understand why a member of the family is depressed, and why can't they just get themselves together. So we need to educate the community about depression, what it is, and how it manifests. And it's estimated that in India itself, over 56 or 57 million people are suffering with depressive disorders. Again, coming back to that global figure, about 4.5% of the total population. But another epidemiological study in India showed it was almost 16% depressed. So we don't know where the true figure lies in terms of how common depression is in India, but it could certainly be a very significant problem. And the total years lived with disability, so they're not contributing economically, is over 10 million. So, just so I repeat myself, so you hear the message loud and clear, who is affected by depression? Everybody. Everybody can be affected by depression from all walks of life. And when someone's depressed, it can affect the whole society, their family, their friends, loved ones, etc. We know that the risk of depression is higher in people who've got problems: poverty, homelessness, unemployment, those who've suffered significant life events, such as the death of a loved one or a relationship breakup, and those who've suffered abuse, especially children, women, and the neglected elderly. And people with especially chronic physical illness can also have a depression. We know that people with chronic physical illness, almost 30% will develop a depressive illness that needs assessing and treating. So what are the clinical features of major depression? Obviously, there is sadness or a low mood. Sometimes people can be tearful. Sometimes when they get very depressed, even the tears stop. And the affect or the mood is just very flat. They also, often people have what's called anhedonia, the inability to get any pleasure out of anything, even things they used to love doing or really enjoyed. We know that the sleep can be affected, and while there can be often difficulty getting sleep, the main sleep abnormality in people with depression is early morning wakening. They wake up very early, 4 o'clock, 5 o'clock, feel unrefreshed and can't get back to sleep. Often their energy feels very low or they feel fatigued. And often people who are depressed feel guilty or worthless. I often ask my patients when I'm assessing them, some people with depression express the fact they feel guilty about things or worthless, and often the patients say to me, that's me. I feel guilty, I feel a burden on my family, I just feel as though I'm no good whatsoever. Often there's loss of appetite, which can be accompanied by loss of weight. Often the activity levels go down and people will be quite slow in answering questions or any kind of activity. And of course, there are suicidal thoughts and suicidal ideas. And most worrying is when I talk to patients who've made a plan, who know exactly how they're going to do it, who've made all the preparations, and those people I normally admit to hospital. And people often complain that their memory is poor, that they can't concentrate and they can't remember things. There are other features as well. There can be anxiety features. There can be irritability and anger, and even more severe inability of their brain to work properly, called cognitive dysfunction. So you've seen somebody, you think they're depressed, how can we treat them? How can we help them? Well, the initial therapy treatment consists of either therapy, talking therapy, such as cognitive behavior therapy, where the thoughts, those negative thoughts are challenged, and or initiating medication, antidepressants. If you're worried about the person, or if it's a complicated presentation, then you may need to refer on to a psychiatrist. And sometimes even when we start treatment, the treatment may not work, and there are multiple reasons why treatment doesn't work. Often, and you have to ask the patient about this, they haven't taken the tablets. So there's poor adherence. And if you don't take the tablets, it's not going to work. Also, if they do take the tablets, you can get a reoccurrence or a breakthrough of symptoms, and so maybe the dose of the medication needs to increase. There may be undiagnosed medical conditions that are making response to treatment difficult. And there may be other psychiatric disorders, such as anxiety, that also need to be treated in their own right. And some people don't like taking the medication because they complain of side effects. And then there are some people who truly are treatment resistant, and then we need to have a lot more sophisticated ways of managing those people. Now, the most common place for depression to present is in primary care, to the primary care doctors. And it's stated here that at least a third of patients who see their GP or primary care doctor have a psychological disorder. I actually think that figure is too low. I think it's about 50%. And depression is seen as the most common psychological disorder in primary care. But of those who present who've got a depression, less than half receive an adequate assessment. So the doctor doesn't think about excluding depression or finding there's a diagnosis of depression. But even if they do get an adequate assessment, less than half of those diagnosed receive adequate treatment. So the figures are really not very good, but it's something we could do something about. And it's from what we've kind of from the literature, in India, patients with depression often have somatic symptoms, such as pain. And they will present more of that than with complaining about being depressed. So what are the barriers to people getting help? Well, there's a lot of ignorance out there, lack of knowledge of what depression is. There's also a lack of help-seeking behaviour. And then, of course, there's the big elephant in the room, which is stigma. Stigma of psychiatric disorders stops the majority of people from getting help. And that is what we as a society should be doing to reduce stigma. We know that depression, if it's untreated, can result in chronic disability, poor quality of life, increased comorbidity of things such as substance use or alcohol use, and increased suicide risk, and a higher relapse rate. And demoralisation. It is grim to be living with those depressive symptoms. And it also has a toll on the family. So what should we be doing in an ideal world in recognising and being more effective at assessing and treating depression? Well, we should think about optimising screening for early identification and treatment of depression. Nothing too complicated, just screening tools that could be completed by patients in the waiting room. Promoting the best practice in the management for both specialist and primary care of depression. Reduction of cultural barriers and reduction of stigma to promote access to care. Having clear pathways that if a primary care doctor can't treat the depression adequately, that they can then refer on to a specialist. And the capacity to work with traditional healthcare systems. They're very important to people, and we should embrace them and work with them. And training in relapse preventions as well. Now, I think the key to this is community support, whether it's in Australia, whether it's in the UK, whether it's in India. In Australia, we're lucky in having a number of community support groups, including Mind Australia and Beyond Blue. Beyond Blue has a specific remit about educating the population of Australia about depression. And this young gentleman here, Tom Mackay, walked from Bekal, India's west coast, to the Bay of Bengal, raising $13,000 for Beyond Blue because of his own personal experience of anxiety and depression. We also know that young men especially are not very good at talking about how they feel. And in Australia, we have a Are You OK Mate Day. And it's an attempt to get young men to have a conversation about what their feelings are and how they're feeling in order to reduce depression and suicide amongst this population. So finally, what key public information should we be getting out there? And this is from Beyond Blue, and this is an Australian message, so it may not be appropriate for India. 1, depression is a health problem. It's not due to lack of morals or weakness. It is common, and it's likely to affect every family. It's a community problem, and it requires a community response to reduce stigma and problems such as that. And those with depression need help to get care, to get better. Close family and friends need to be educated. They need to recognise the early signs of depression, such as failing at work or school, social withdrawal, increase in alcohol use. And we need what would be great, it's the kind of thing we have in Australia, is a coordinated national depression strategy. And participation in this discussion by key political, media and community leaders. And a little bit later, Julia will introduce one of our previous government ministers who's been very open about his experience of depression. We need to invest in primary care education programs, population-based prevention and early intervention programs, and the partnerships, promote partnerships between health, education, business and community support groups. And one thing we've been advocating and got some success at in Australia is reform in mental health services and insurance schemes, so that decreases that as a barrier to care. And so this is just an information sheet that the World Health Organization publishes saying what depression is on the left and what can you do if you think you are depressed. And I think it's making these kind of leaflets available to the patients we see, making them available in communities, that will start that, hopefully, that national discussion to improve both assessment and management of people who are suffering with depression. Thank you very much. I hope you've heard or understood a bit more about depression. Thank you.